Welcome back, clinical problem solvers, to another Rafin Medina subspecialty VMR series. Today, we'll be having an amazing oncology VMR with Dr. Neelima Vidula as a case discussant and with Dr. Andrew Knight as a case presenter. It's our pleasure to have you on this session, Dr. Vidula. And before starting the session, I would like to introduce Dr. Neelima Vidula. Dr. Neelima Vidula is a breast medical oncologist at a Massachusetts General Hospital and an assistant professor of medicine at Harvard Medical School. And she completed her medical school and internal medicine residency at Northwestern University in Chicago and did her fellowship in hematology and medical oncology at the University of California, San Francisco. In terms of research, Dr. Vidula is a principal investigator of many early phase clinical trials studying the novel agents for patients with breast cancer. Thank you so much, Dr. Vidula. If you want to unmute yourself and introduce yourself to the audience.
Thank you very much for that kind introduction. It's really a pleasure to be here, and I hope that we'll have a great session today.
Awesome. Thank you so much. And now we have Dr. Andrew, who is our case presenter today. And Dr. Andrew has completed his internal medicine residency at the University of Pittsburgh Medical Center and is currently a PGY4 and Hem-Onc Fellow at the Massachusetts General Hospital. Welcome, Dr. Andrew. Do you want to unmute yourself and introduce to the audience?
Hi, everybody. Thank you all for having me today. Looking forward to the case.
Awesome. And Simi, if you are ready, I think let's get started. If you can share your whiteboard.
Yeah, sure.
Dr. Andrew, you can start whenever you are ready.
All right. So this is a case of a 56-year-old woman with a past medical history of triple-negative breast cancer that was diagnosed 1 year prior. She declined any further workup or treatment at the time of diagnosis, and she presented to our emergency department approximately 1 year later with a fungating breast mass, lower extremity weakness, and lower extremity numbness.
Thank you so much, Dr. Andrew, for this first aliquot. Dr. Vidula, how are you going to characterize the symptoms now? We have a background history of the triple-negative oncological tumor now presenting with the new onset lower extremity weakness and numbness. And how do you interpret these symptoms in the background of tumor? And what additional questions would you like to ask this patient to frame your initial DDX?
Thank you. So given the fungating breast mass and the history of triple-negative breast cancer, from the start itself, I'm worried that this presentation could be related in part to a breast cancer recurrence or spread of the breast cancer to the spinal cord. And I think that needs to be high on your differential from the beginning. In terms of additional questions to kind of characterize what's going on with this patient, I would find out, she has lower extremity numbness and weakness. When did that start? Has it been getting worse with time? Does she have any other symptoms? Is she having back pain? Is she having urinary or fecal incontinence or retention? What other symptoms does she have? Anything, other systemic symptoms like difficulty breathing, abdominal pain? Because often if a patient with breast cancer has recurred in one area, it's also possible there may be recurrences in other areas as well. And then I think in terms of the breast cancer itself, it's important to find out, how is this managed? When did she, notice the breast mass? Has it been getting bigger with time? What's the, natural history of this? Has she received any kind of treatment? It sounds like she declined further workup, but, I would try to find out what was she, pursuing instead.
Wonderful. Thank you so much, Dr. Vidula. Dr. Andrew, would you like, if you don't mind, would you like to move to the next aliquot so that we can have some detailed discussion?
Certainly. So I'll start chronologically here. If we go back about 2 years prior, in the spring of 23, she was able to palpate a breast mass on the left. and also a mass in the axilla as well. And later that fall, she presented for evaluation and had a mammogram, which showed a spiculated mass in the left upper outer quadrant of the breast, approximately 4 centimeters from the nipple. 2 weeks after that, she had a biopsy arranged, which confirmed poorly differentiated invasive ductal carcinoma, measuring 1.6 centimeters on that biopsy. It was found to be triple negative, so that's negative for ER, the estrogen receptor, progesterone receptor, and HER2. She then had a biopsy of the left axillary lymph node, which also did show evidence of involvement by the carcinoma. She subsequently had a staging PET scan done, which did show an FDG-avid breast mass, as well as enlarged left axillary lymph nodes measuring up to 1.8 centimeters, and notably FDG avidity in the right posterior 6th rib and a FDG-avid left pulmonary nodule concerning for metastatic disease. At that point, she had consultation with oncology, and upon discussion that she would be recommended to receive chemotherapy, she did not, she was concerned about the side effects and did not follow up further for treatment. Subsequently, she noted some breast ulcerations starting about 1 year prior to her presentation here. She had been receiving wound care for that, actually went back to the Dominican Republic, where she's originally from, continued to receive local wound care, but no systemic therapy. I can pause there if you'd like. I continue to give the presentation leading up to the ED presentation.
And whatever works for you, Dr. Andrew, that's completely fine.
Great. I'll just give a little bit more information about her symptoms in the week preceding her presentation. So about 5 days before she showed up, she said she developed some gradual onset paresthesias and lower extremity weakness, stating that it had progressed to the point where she was no longer able to ambulate. She'd been using a wheelchair and relying on her family to move around her house. So she also reports that along that time course, she developed diminished sensation throughout the lower extremities, and this was associated with multiple episodes of urinary incontinence, and she's now wearing diapers as a result. She had fecal retention, but no fecal incontinence, and stated that her last bowel movement was approximately 5 to 6 days prior to presentation. She is passing gas, has not had any nausea, vomiting, or fevers. She reports some fatigue, but denies chest pain, shortness of breath, palpitations, headaches, or changes in vision. She does note some discomfort over the anterior chest wall, where she has a wound associated with the fungating tumor on the left side, where she was receiving local wound care.
Thank you so much, Dr. Andrew, for sharing such a rich aliquot. So, Dr. Vidula, now how are you going to interpret? Now we have a rich and metastatic breast cancer, and some, I think I'm just seeing some kind of osseous lesions on the bone. And now, how are just changing your differential diagnosis here with a given onset of neurological symptoms?
Yeah, so this is an unfortunate situation. It appears that this woman unfortunately had a large breast mass that at this point, potentially may have spread to other areas, had rib metastases at the time of diagnosis. And given her current presentation, I am quite worried that she may have breast cancer that has spread to the spine, and in particular, whether she potentially could have spinal cord compression. I think that's very high in the differential, given that breast cancer, likes to travel to the bones, and she has an untreated advanced breast cancer. So with time, the natural history of that disease is such that without treatment, it will spread and it can cause complications. So definitely cord compression is high in the differential. That said, I think you also have to worry about other things that could be contributing here. For example, could she have some kind of an infection in the spinal cord that might help might explain some of her symptoms? Something like Guillain-Barré is also possible, although typically you'd see ascending weakness primarily before descending. I think you also have to think about, other causes of weakness. Could there be some kind of a myopathy or some kind of muscle disorder? But this would definitely be lower on the differential.
Wonderful. Thank you so much, Dr. Vidula. Now, I mean, in general, we have been during our medical school, we have been taught that, in general schema to approach weakness or numbness. Now, is it going to change your needle in terms of oncological history? Does it change your needle right now? Anything you have to do aggressively just to save this patient?
Given the high pretest probability that this patient may have a recurrence in the spinal cord, I think that you really need to have spinal cord compression high on your differential, and we need to really think about getting some urgent spinal imaging because this patient has a known cancer diagnosis. She has triple negative breast cancer, which tends to be aggressive. She had metastatic disease at the time of diagnosis, so it's very, very possible that she could be developing metastases in a different area. And then I think based on the history, it's quite concerning for some kind of compression because this patient now has had 5 days of paresthesias and weakness, and this has progressed to the point where she cannot walk and is also losing control of her bowels and bladder. And all of those symptoms are red flag symptoms for cord compression.
Wonderful. I really loved your thoughts on the entire approach to this scenario. And I'm just curious to know, I had a similar case back in my medical school without having a history of the tumor. Now, do you want to, let's imagine this patient sitting in the ER. So do you want to wait until the neurosurgery and until the patient gets a pan MRI? Or do you want to empirically start any kind of medical management because we are dealing with the nerve, because time is the important factor here, right? So how do you approach this scenario in from your practical perspective?
Yeah, so I think from a practical perspective, this is somebody you want an urgent MRI spine on. The good news is that usually if you're in the emergency room, this would receive priority. So hopefully you could get the patient into the scanner soon. In terms of empiric management, really the treatment at this point, if you wanted to do one thing, start one thing would be to start some steroids. That said, I think that the one, definitely for in terms of neurologic recovery, in this particular case, this has been going on for 5 days. I don't know how much neurologic recovery we're going to be able to expect because it's now progressed to the point where the patient is not able to ambulate and is losing control of her bladder and bowels. The downside to steroids is that, the one thing you might be missing here is could this patient have some kind of an abscess or an infection? And could that make things worse? That's why I think that since you don't really, this is somebody who had a fungating breast mass, it's also possible that got infected and could, she could have an infection in the spine. So I think ideally, if you're able to get her to an MRI scanner ASAP, that would be the preferred approach. And, an MRI scan takes about 45 minutes, so in and out, and you should be able to get a quick read. If you're not able to, if this is going to take 1 or 2 days, then yes, then I would probably start a dose of steroids because as long as she's not febrile or has a leukocytosis, it's less likely that she has an infection. That's the only thing that on the differential that would probably get worse with a course of steroids.
Wonderful. I really loved your thoughts. And before moving on to the next report, I have one question for you. Does any information clues on the medication or any kind of significant past medical history and adds any value to your DDX right now in this scenario?
Well, in terms of medications, I would want to know, is this patient, it sounds like she didn't get any treatment for the cancer, but I'd want to know, has she, been on anything that might suppress her immune system or might have a cytotoxic effect? So it sounds like she was in the Dominican Republic. Did you get any kind of, alternative treatment or something that would be helpful to know too? And then, and sorry, what was the second question again?
I'm just curious to know whether there's a past medical history apart from the medications or in kind of family history or relevant social history is going to change your in your differentials. Yeah.
I think the highest worry here is, of course, that this patient may have triple negative breast cancer that has spread to the spine, and breast cancer certainly can do that. It would be helpful to get a quick family history to find out if there are any other malignancies in the family, because not to want to give the patient a second diagnosis, but it's possible that there could be some other type of cancer that's presenting itself like this. For example, lymphoma can present with cord compression or lung cancer. So I'd want to just quickly know, is she a smoker? Is there any other family history of cancer? And then one other good teaching point is that triple negative breast cancer can sometimes be seen in association with a germline beard or CA mutation. And that is something that can predispose families, runs in families, and can predispose families to ovarian cancer, prostate cancer, and so forth. So it would be helpful to get a sense of whether there are other cancers in the family to figure out if, in the off chance that she might have another malignancy that could be presenting here. That being said, given that she has an advanced triple negative breast cancer that has a propensity for spreading to the bone, that would probably be highest on my differential.
Awesome. I loved all your clinical pearls in this scenario. Back to you, Dr. Andrew.
And
All right.
the only other thing I'd add is also just to find out, does she have like any history of like spinal issues, like, has she had like spinal stenosis in the past or something like that? Because, could she have like a herniated disc or something, that's causing some issue here at this point? That's also a possibility, although lower on the differential.
Awesome. Back to you, Dr. Andrew.
All right, so to fill in some of her past history, here, her past medical history, she has uterine fibroids, had a myomectomy in 2018. She otherwise just has migraines. She's not currently on any medications, denies any other treatment for the breast cancer in the Dominican Republic aside from local wound care. She said that she has no history of cancer that runs in the family. She has 2 sisters as well as 2 stepsisters and 1 child, all of whom are reportedly healthy. She used to work in sales, does not smoke, no current alcohol use, and no history of prior heavy use, no recreational drug use, not currently sexually active. And just to highlight that no other surgeries besides from the myomectomy, particularly no spine surgery. With that, I'll go into her physical exam. Vitals, her blood pressure was 130/78, pulse 87, afebrile, respirations 19, satting 99% on room air. In general, she was frail appearing. Extraocular movement was intact. Respiration rate was normal. Lungs were clear throughout with no increased work of breathing. Heart was regular rate and rhythm with no murmurs. She did have a distended abdomen without tenderness to palpation, no rebound or guarding, no CVA tenderness bilaterally. She did have midline tenderness to the thoracic and lumbar spine on palpation, no C-spine tenderness noted, no bilateral extremity edema, so lower extremity edema. She did have a 4-centimeter wound over the left anterior chest wall with erythema without obvious bleeding or purulent drainage. She did not have any cranial nerve deficits. Her speech was normal. Her mental status was normal as well. She had 5 out of 5 strength in the upper extremities. However, 0 out of 5 strength in the lower extremities, unable to make any effort against gravity. She did report diminished sensation throughout the bilateral extremities, with essentially no sensation to light touch, no clonus detected. And she also had sensory deficits that essentially went up to about the level of the umbilicus.
Wonderful. Thank you, Dr. Andrew. So, Dr. Vidula, now we have this 56-year-old woman with metastatic triple-negative breast cancer, now presenting with the acute to subacute progressive lower extremity weakness, sensory loss, and in the setting of fungating chest wall mass with prior, osseous metastatic lesions. And now, how do you interpret the physical exam here? And now, as you mentioned, there could be a chance of infection breast wound. And now the patient is not having any kind of fever. Does it rules out infection for you so that you can safely inject the steroid? And how do you interpret that?
Yeah, so first of all, just another teaching point about the exam. I think that overall it sounds like a very thorough exam and good neurologic exam. But the one thing that I would also highlight for the trainees is that you should also be examining for anal sphincter tone. Often the rectal tone is diminished in patients who've had spinal cord injuries or in cord compression. So that's something that, as long as the patient is not neutropenic, would recommend doing as part of the physical exam here. In terms of this patient's physical exam, basically, to summarize, she has no strength in her bilateral lower extremity and also diminished sensation over the bilateral lower extremity. So I think that, given that it's bilateral, one of the things we didn't talk about earlier was that, of course, in somebody presenting with weakness and numbness and tingling, you should be thinking about stroke and CVA. I think that's less likely here, given that it's bilateral and given the worry for, breast cancer metastasis. In terms of the infectious concern, she does have this large wound over her chest wall, which certainly, but it sounds like from the description of it, there's just some erythema, but there's no obvious drainage or bleeding. So I think infection is less likely to be the case here. So I think that again, ideally, if you're able to get an MRI done in the next 45 minutes, just go get it done, and then you don't have to worry about there being an abscess there or not. But I think that's far lower on my differential. So if there's any delay to getting an MRI, then go ahead and you could probably start 10 milligrams of IV dexamethasone followed by 4 IV Q6 is typically what we recommend starting for cord compression.
Awesome. And I have one more question for you here. I mean, now in the abdominal exam, we are seeing some distended abdomen. So do you think it's kind of noise here, or is it adding any value to your DDX in terms of further ordering the imaging?
Yeah. So I think, in terms of additional imaging, I would image her CT chest, abdomen, and pelvis as well, because in general, if there's a recurrence or spread of malignancy to one spot, there could very easily be spread to other areas too. And I think you want to get a complete sense of where are the potential metastases in this case. So I think this patient is already signed up for having a CT chest, abdomen, and pelvis, and a total MRI spine. I would also probably have a low threshold to get some kind of brain imaging too, just because even though this is more likely to be spinal cord involvement, could she in theory have a very large mass lesion in her brain that is causing bilateral lower extremity weakness? Theoretically, it's possible. Seems less likely. She doesn't have any headaches or nausea or vomiting, but just because triple negative breast cancer does like to go to the brain too, I think it is reasonable to get that type of imaging. And then I think in terms of the distended abdomen, though, what I would be more concerned about, even though you will get the abdominal imaging, is she retaining urine at this point because of concern for spinal cord compression? And so if, I'd go assess whether the patient is, you could even do like a bladder scan and see if she's holding onto urine or able to urinate on herself, by herself. She may eventually need a Foley catheter. That's often the case for patients in this kind of situation.
Loved your thoughts, Dr. Vidula. And back to you, Dr. Andrew.
Right, so I'll give a couple of lab values now. So notably on the CMP, the patient was just mildly hyponatremic at 132 with a chloride of 95. Renal function was at baseline with a creatinine of 0.7, BUN 13. LFT is notable for a normal AST, ALT at 22 and 18 respectively. Alk Phos was mildly elevated at 136. On her CBC, her white count was normal at 7.6. Hemoglobin was 9.6. Platelets normal as well at 276. So anemic there with a hemoglobin of 9.6. Diff was essentially unremarkable. And an ESR was sent while she was in the ED as well, which came back highly elevated at 84. I'll also highlight the imaging that you want me to get into the imaging at this point?
Yeah, if it works for you, yeah, you can go ahead.
Sounds good. So she did urgently have an MRI of the spine, which was notable for T6, T7 epidural metastases with a T6 compression fracture with spinal stenosis and evidence that there was impingement on the spinal cord. She did also have a CT chest, abdomen, pelvis, which showed that there was likely a primary breast malignancy infiltrating throughout the left breast, some large left axillary adenopathy, and osteolytic metastases throughout the T-spine noted on that CT as well. On the abdomen pelvis, she had evidence of multifocal liver disease in addition to osseous metastases sort of diffusely throughout the lumbar spine and pelvis noted as well.
Awesome. And Dr. Vidula, now how are you going to interpret the hemoglobin of 9.6? So do you attribute that because of the any iron deficiency anemia or any anemia of chronic disease? And what kind of next step investigations would you like to order and to make that to achieve the progress in this case?
Thank you. Yeah, so I would, looks like do we know the MCV for this patient? Is it normal?
We do. Let me just pull it up here. It looks like the MCV was low normal at 83.2.
I think that, given that this patient has an active malignancy that appears to be untreated, probably anemia of chronic inflammation is most likely to be the etiology here. I would definitely send a ferritin and a TIBC and an iron level to work that up. It's possible there could be iron deficiency too. And then while you're at it, a B12 and a folate, given that the MCV was actually normocytic. But you could just kind of quickly work up this. But my suspicion is that it'll end up being an anemia of chronic inflammation.
Awesome. And I have one more question here regarding the MRI. Now we are seeing the epidural metastasis probably with C6 compression and causing all these lesions. Now, I mean, what is how do you wanna go for the MRI of the brain as well, just to look for any metastasis in the brain or suspecting any kind of leptomeningeal carcinoma? And what is your reflex thought on that?
Yeah, so just one other point about the anemia, given that this patient has a breast mass, a fungating breast mass, those do often have a propensity for bleeding. So I would also assess for bleeding. It sounds like on the exam there wasn't any, but often these breast masses can be very prone to bleeding, and that could potentially explain the anemia as well. In terms of the imaging, I think the imaging is very concerning, and you have a diagnosis, that this is likely cord compression. I think that in terms of getting an MRI of her brain, I don't know that you necessarily need one here because there's no indication clinically that, she's having headaches or nausea, vomiting, or anything to make you think that there could be CNS involvement in addition to it. Often our radiation oncologists will want an MRI brain just because then, they can get a full picture. And also this patient has kind of been lost in medical care and so forth. So I would have a low threshold for getting one, but I don't think that, if this was a board's question, that you need one at this point because she doesn't really have any other symptoms that would make you think she has a brain met. And two, you have a diagnosis based on the imaging of spinal cord compression.
Thank you so much for the clarification. And I have last question. So now we have a classical picture of cord compression. So do you think it is sufficient to make the diagnosis here, or else do you prefer to get a more advanced imaging just to have this further solidified diagnosis?
So I think this patient has had a total spinal MRI, it sounds like, that is showing epidural mets and compression. And so I think you do have a diagnosis at this point that there is spinal cord compression. Of course, the question that arises is what's causing it, what's the malignancy, the driver. I think I would go back. It sounds like this patient did have a biopsy potentially in the past, maybe when she was seen. But if she hasn't, I would go get a breast biopsy or find an accessible lesion. Often, I think in terms of the scans, if there's another accessible site to easily biopsy, that would be good. This helps us confirm that there is a malignancy and also to know what the malignancy is. And then just a teaching point in terms of the site of biopsy. I think, a breast biopsy certainly is not unreasonable because you have the breast tissue there, you could definitely get it. But I think if you have a distant accessible lesion, for example, a lymph node or a liver lesion, that allows you to not only diagnose the cancer, but to also stage it. Okay. And now we do think that she has advanced cancer here, but the other benefit of getting a biopsy of a distant site is that in about 10 to 15% of cases, cancer can actually mutate. Breast cancer can mutate from its starting point from the breast to if it goes to the liver or something, and in a distant organ, and that allows you to confirm that this is still a triple negative breast cancer. In terms of biopsying the spine itself, I think that that's often a more difficult area to biopsy. Now, one of the things that you'll definitely want to do at this point is consult neurosurgery. And if they end up taking her to the operating room, then you'll have the surgical pathology specimen and that solves that issue. But often the reason why we prefer a visceral site over a bony site is because there can be decortication of the receptors on the bone.
Wonderful. Thank you so much, Dr. Vidula, for filling my knowledge gaps. And Dr. Andrew, back to you. And I'm looking forward to learning from your case now. Really excited.
Great. Well, thank you to Vinmit for pointing out we need the lumbar spine MRI as well, which does show that there is also an osseous lesion in the left sacral wing with some compression of the sacral nerve roots along the neural foramina there as well. To show that they also then went forward with neurosurgical consultation. At that point, she was started on steroids, but after discussion with neurosurgery, they felt that given the time course and the dense neurologic deficits that she had, that urgent neurosurgical intervention was unlikely to benefit the patient. However, she did receive palliative spinal and breast radiation for purely for palliative intent there, which was completed without complication. They did proceed with biopsy of one of the liver lesions, which confirmed triple negative breast cancer, ER negative, PR negative, and HER2 0 on that biopsy. So at that point, there was consultation with oncology regarding systemic therapy. And I'm curious if I can ask Dr. Vidula a question about how you would approach a patient like this who's previously declined therapy and now is presenting with a more significant presentation like this.
Yeah, thank you, Dr. Knight. So first of all, just a couple of teaching points here. So I think that with regard to the MRI, definitely you want to get an MRI total spine. I did think that originally she had had that, but it's good, Dr. Knight, that you clarified that they were able to complete the rest of the imaging. The reason for that is if you have metastases in one area of the spine, there's a very high chance that you might have it in other areas. And in terms of thinking about what's the best way to manage symptoms and also to manage the disease in this area, having the full picture will help the radiation oncologist and also the neurosurgeon weigh in terms of managing it. In terms of management of this disease, so the team very appropriately called neurosurgery because, you know, the first goal is, you know, in these types of cases where a patient has cord compression is to see what you can do to mitigate the risk of progression of neurologic deficits. So just taking a step back, typically for patients who are presenting with cord compression, the first symptom often tends to be low back pain. And that is something that can happen for, you know, many weeks, even maybe even months before the onset of sensory deficits and then weakness. So motor deficits, which is what we're seeing in this case, are really pretty advanced in terms of the spectrum of cord compression. And I think that that's probably why the neurosurgery team in this case deemed that this patient would not really benefit from surgery because probably the damage to the nerves had progressed to the point where she was not able to ambulate and, you know, there wouldn't be much perceived benefit, and it is an invasive surgery. But in general, you know, if you're able to operate on something to rapidly decompress the impact on the nerves in the spinal cord, that is typically what we'll try to do first. But again, unfortunately, this patient, it seems like missed her window for that. So probably that's why it wasn't done. And then in terms of other management, you know, we're thinking about radiation and then we're thinking about systemic therapy. So going back to your question, Dr. Knight, in a patient who has previously declined therapy now has a very serious complication of malignancy. How do you move forward? And that's where I think it's really important to sit down with the patient and try to understand what were the reasons for declining therapy. And very often one of the reasons in patients who have a fungating breast mass, you know, and haven't received care, is probably fear. There's probably a very large component of fear and worry and, you know, also denial, hoping that this will all just kind of magically go away. And, you know, I think that so in this type of situation, I think it would be really helpful to sit down with the patient, to build trust with the patient, and then try to understand where is the patient coming from? What were the reasons in the past for not wanting treatment? What's your understanding of the current situation? And then explain to the patient that this is a more serious situation than you were in previously because now there's spinal cord involvement that has unfortunately progressed to the point where the patient is not able to ambulate. And in terms of thinking about next steps, our goals really are twofold. One is to palliate symptoms to prevent further neurologic deficits from occurring based on the spinal cord compression, and also to help the patient feel better, and two, prolongation of life because she has metastatic triple negative breast cancer. And we know that untreated, that is something that unfortunately patients will die from. With treatment, patients may be able to expand their lifespan. So I think it's really important to sit down with the patient and try to understand where she's coming from, and then also to help her understand where you're coming from in terms of recommendations. And, but I think you should also call, radiation oncology here to see what they can offer in terms of local management of the spinal cord metastases, and see if they can potentially start radiation urgently to temporize some of the deficits that are already occurring. And then that gives you some more time to think about systemic therapy, which will take a little bit longer to take effect, and also to coordinate it and so forth.
Great. Well, thank you for that. So just to follow through on what happened next, she was evaluated by the rehab team after radiation oncology had provided the recommendations and surgery as well. And they felt that she unfortunately was unlikely to have significant functional recovery of her lower extremities. And at which point they focused primarily on managing some of the symptoms that developed around this neurologic deficit, notably the pain, for which she was started on opiate pain medication, as well as pregabalin, and also started on some muscle relaxers as she developed some lower extremity spasms as well. Again, she was known to have essentially diffuse lytic lesions, so there was also some local therapies applied for some of the pain that she was having at those sites. Ultimately, she did consult with medical oncology, and the decision was made to start on weekly Taxol. So I'm curious if you can discuss why somebody might choose weekly Taxol in this case.
And thank you. And Dr. Knight, to clarify, so did the patient end up starting radiation then?
She did. She received radiation actually starting while she was in the hospital, to both the breast, the primary site, as well as to the thoracic spine lesion.
Great. So yeah, I think that the way this patient was managed sounds very reasonable. Given the acuity of the presentation, radiation often takes effect a little bit faster than systemic therapy can. So local control, to try to temporize the spinal metastases to keep them from further progressing and causing even more neurologic damage than there already is. It's good that the pain management service was seeing the patient and helping manage pain. And then I think they probably decided to radiate the breast, I'm guessing, just because it might have been friable and there was concern that that might also bleed, or perhaps there was pain in that area as well. In terms of systemic therapy, so now, we have after finishing radiation, usually a couple of weeks afterwards, that's when we'll be thinking about starting some systemic therapy, because we know that this patient has widespread metastatic disease. And the goal of systemic therapy really is twofold. One, to palliate symptoms, and help reduce pain by treating the cancer itself. And two is to prolong life. And so the management of triple negative breast cancer that's advanced or metastatic typically involves chemotherapy. This is an incurable disease, but with treatment, patients may have better outcomes and may be able to live for a longer period of time, even though the average survival from metastatic triple negative breast cancer tends to be around 2 years. When we think about first-line therapy for metastatic triple negative breast cancer, it's really important to know what is the PD-L1 or programmed death ligand 1 status on the tumor. And this is basically an immune biomarker. And it's based on a study that demonstrated that in patients who have programmed death ligand 1 or PD-L1 positive triple negative breast cancer, they actually benefited from the addition of immunotherapy to standard chemotherapy compared to chemotherapy alone. So that is typically one of the biomarkers that we're looking for upfront. And then I think in terms of thinking about systemic therapy, it's also important to offer the patient germline genetic testing, because we know that some triple negative breast cancers may be seen in association with germline BRCA mutations. Now, germline BRCA mutations are not very common. They're seen in about 5% of breast cancer. But that being said, if a patient were to have a germline BRCA mutation, then they may be eligible for a PARP inhibitor, although that's typically given, after receipt of initial systemic chemotherapy. So definitely on the liver biopsy that was done for this patient, I would send the PD-L1 testing. In the meantime, though, in terms of thinking about systemic therapy, we're usually thinking about chemotherapy for triple negative breast cancer because, triple negative breast cancer is defined as malignancy that's not expressing estrogen or progesterone or HER2, the biomarkers we typically look for in breast cancer. So it has less targeted therapies that are available than other subtypes of breast cancer. The mainstay of treatment is chemotherapy. In terms of first-line chemotherapy, because the study that looked at the addition of immunotherapy in PD-L1 positive tumors, the immunotherapy agent was pembrolizumab, combined that with a taxane or gemcitabine and carboplatin. Often we'll think about starting a taxane up front because then it'll take the PD-L1 testing some time to come back, and you may be able to easily add the pembrolizumab if it comes back as PD-L1 positive. Okay. And then in terms of, single agent versus doublet chemotherapy, typically we try to maximize the use of single agent chemotherapy up front, just because as long as the patient's not having a visceral crisis or in a very severe presentation, because that minimizes toxicity and so forth. And this patient's chemo naive, so I would say that a single agent would be quite reasonable here. So I would be thinking about weekly paclitaxel, which was again used as a partner for the immunotherapy in the study that led to the approval of pembrolizumab and a taxane in patients that are PD-L1 positive with metastatic triple negative breast cancer. Weekly paclitaxel has the benefit of being pretty gentle in terms of chemotherapy. We usually dose it 3 weeks on, 1 week holiday. If you had had the PD-L1 status up front and you knew that it was PD-L1 negative, this would still be a reasonable option. Sometimes in patients who are PD-L1 negative, we would think about an oral agent like Xeloda, capecitabine, as something to ease them into chemotherapy. That being said, with this patient, I think I would be a little hesitant about giving her Xeloda because that puts a lot of the work on the patient. You have to be able to take pills. There's our pills at home. And so it'll be pills, twice a day, 2 weeks on, 1 week holiday. And in somebody who, wasn't previously seeking care, has a lot of disease burden, I think it would probably be easier and probably in her best interest to give her something intravenously that dose got in, and also takes the work off of her. Also, in somebody who is has spinal cord compression and now has fecal incontinence, diarrhea from Xeloda might be very problematic, and and in terms of managing that too, and just symptoms. So I think that I would probably lean towards weekly paclitaxel for all these reasons.
Excellent. And I'll add to that her PD-L1 testing or PD-1 testing did come back negative, just to support that. One question that I had from a practical consideration was what to do if a patient is unable to have an MRI, but has a similar presentation to this. I had seen somewhere that CT myelography can be used as an alternative. Is that something you have experience with?
Yeah, I think that if it would be, if a patient had some serious contraindication to getting an MRI, for example, like some metal implant that just, can't be worked around, then I think CT scans are very reasonable, like a CT of a spine or a CT myelogram. It certainly could be an alternative. Really, at the end of the day, you just want to be able to image the spinal cord. And even though MRIs usually are preferred choice, a CT is reasonable in the cases where you can't do an MRI.
The other thing I wanted to emphasize there as well is as I was going through the history, you picked out so seamlessly what the questions are that you would want to ask a patient like this to specifically get at whether or not you should be more or less concerned about cord compression. But just to highlight that a little bit more, could you pick out specifically what the signs and symptoms are that make you think that spinal cord compression is high on your differential?
Yeah, so first of all, the underlying malignancy, knowing that she has a untreated malignancy, your differential is high when you suddenly have lower extremity neurologic deficits. I think you have to have spinal cord compression high on your differential for a patient who has an active malignancy. So that's one thing on the history that definitely stands out. Then in terms of other components of the history, the patient noted that she is having a diminishing sensation of her lower extremities. She's also been having weakness that has progressed to the point that she can't ambulate. This is also worrisome for spinal cord compression. I don't know that you mentioned that whether or not she had back pain, but often, as I was saying before, back pain is often the first symptom of cord compression. So it would be helpful to know if she had had a history of back pain sometime. It could have started even many months prior to all of this kind of acutely worsening. Then looking for fecal and urinary incontinence or retention, those are often signs of cord compression as well. On your physical exam, looking for lower extremity weakness. And also, we talked before about looking for the absence of rectal tone. I think those are also things that might cue you into spinal cord compression.
Excellent. Well, thank you for that. I chose this case in part because back pain is such a common presentation. And I think in recent years in particular, there's been a particular emphasis on trying to de-escalate who we get imaging in. And so I think it's important to remember what those red flags, signs and symptoms are to really highlight who does need urgent neurologic imaging rather than waiting and receiving physical therapy, for example, for a few weeks before presenting. This patient certainly did have back pain at presentation, and that was her presenting, or would have been her presenting symptom had she presented sooner. It wasn't until actually a couple days into the back pain that she developed these other neurologic symptoms, which subsequently progressed.
And I think that that's an excellent teaching point, and I think in terms of differentials, it really depends on the patient's history, right? So if you have a otherwise healthy woman who comes in and says, I'm having lower back pain, doesn't have any neurologic deficits, then that is a patient that you probably would say, let's try an NSAID and let's try some physical therapy. But then if you take that same scenario and you add in cancer, I have a history of an active cancer, that's when I think you have to have a lower threshold for getting imaging sooner, because in that patient, the likelihood of having something going on in the spine is higher than in a patient who doesn't have a history of malignancy. And then I think the other red flag symptoms that should cue you into, even in a patient, regardless of whether they have a history of malignancy, but might cue you into spinal cord compression, are these red flags like lower extremity weakness, neurologic deficits, fecal and urinary retention, and incontinence. These are not things that you should be seeing with run-of-the-mill back pain that is related to degenerative changes or a herniated disc.
Certainly. And two, I would add to that list is that intravenous drug use is in and of itself a red flag for these patients, certainly signs of epidural abscess such as fever. But the other I would add is just immunosuppression. Patients can present with relatively indolent signs of infection and actually have a spinal epidural abscess, for example. So those would be reasons to image sooner rather than later.
Thank you, Dr. Andrew, for the rich questions. And Dr. Vidula, I think this is one of the best oncology VMR, I guess. And you shared a lot of clinical pearls and regarding the management and how do the involvement, the involvement of different consults and how the patient responds and how to communicate with the patient who was refused the treatment before. And thank you so much for sharing your pearls. Dr. Andrew, do you want to share the final diagnosis to the audience? And it would be great if you could share and your reflections on the case and any one or two teaching points for the audience to take away from this session.
Certainly. So overall, this was consistent with spinal cord compression from her metastatic malignancy. She did receive treatment via radiation and then ultimately systemic treatment with the weekly paclitaxel. I think the key points to take away from this case, as I just highlighted, is when to think about imaging urgently in a patient presenting with back pain, certainly in a patient presenting with neurologic deficits such as this patient, and also what questions to ask that patient. Patient may not necessarily report to you that they're having bowel symptoms or bladder incontinence, for example. And so it's important to actually assess for those, both in terms of your history and then also physical exam, as Dr. Vidula had mentioned, doing a thorough neurologic exam to evaluate, for example, perirectal anesthesia. So with that, I'll turn it back to you, Rahul, to sum up the case.
Thank you so much, Dr. Andrew, for sharing this case. As I mentioned, this is one of the best oncology VMR. And as you mentioned, how to interpret the back pain and when to get an urgent MRI versus when not to. And really looking forward to learn from you more and see you soon again on the VMR. Dr. Vidula, again, thank you so much for sharing all. I think it feels like it's top of the head. Again, I'm going to rewatch this video again and again because I'm specifically biased to hem-onc. I mean, I'm really interested in oncology. And if you'd like to share some of the teaching points to the audience, and what are your teaching points?
So cord compression is an actual oncologic emergency. This is something if you're on call at night as a resident or an intern and you are concerned that a patient has cord compression, this is where you do call your fellow and your attending and you manage it as quickly as possible. And, I think we talked about some of the presenting signs and symptoms, the red flags to look out for. So definitely would have this high on your differential in a patient with malignancy who has new back pain with any red flag symptoms, numbness, tingling, lower extremity weakness, loss of rectal tone on exam, and so forth. And really, in terms of the management pearls, getting that urgent MRI as soon as possible and having a low threshold to start steroids because steroids may help reduce edema and help temporize neurologic developing defects. And then it does require multidisciplinary input, so it's really important to get neurosurgery involved and radiation oncology and as well as medical oncology to make a multidisciplinary plan and a path forward for the patient.
Wonderful. And I really loved your thoughts, and I hope audience will already loved your clinical pearls. And I'm really looking forward to learning from your future and see you soon again on the VMR. And thank you so much, everyone, for joining the VMR today. And I hope you have a great rest of the day. Bye-bye.
Thank you very much for having us. It was our pleasure.
Thank you all.
Thank you.